Let's go ahead and get started with documentation dismemberment. We're gonna focus on H and Ps as promised, but we did not put in the head-to-head comparison for me versus resident, so
Yeah, not fun.
not gonna be quite as dismembering as it could be. All right, so as usual, disclosures, we have none. And I guess just to get the new interns oriented to this is actually live recorded. It's not live anymore. It's just recorded CME. So everything is recorded here, but don't worry. We'll edit it out if you say something too crazy. We got that fine. So objectives, as usual, how to improve our documentation for efficiency as well as accuracy and billing and coding. History, RIA systems, exam documentation no longer have any specific requirements. This applies to inpatient. Well, we've talked about this many times with clinic notes, but the rules now apply across all venues of care. So still you have to document what is medically necessary to take care of the patient. That doesn't get you out of it, but it does keep you from having to make sure you check all the boxes that used to be very important on H&P. But now not as much. All right, so we'll put the HPI up there and give you a couple minutes to look over that. Comments, questions, thoughts? Got capitalizations and punctuation.
It does. It makes sense. It flows.
Just 3, I get 3, whatever.
I think tells a good story that kind of covers everything. It's not too long. It's not too wordy. You know, they will read it pretty fast. Got a good ED summary there.
Ball, Smith, Bruce.
You didn't include what the UA showed. Needed.
Didn't include with the UA show in the
How you know they got one?
They got one.
They did. I don't think it's even in here.
Guaranteed.
Place Foley, so they got some urine.
Yeah, place of Foley, so they got some urine. They got urine, they got it, they got to send it. All right, so now moving into all of just the history section that from the pre-populated. A lot of history on this patient.
Yeah. A lot of procedures.
I'm glad the history of density study is still ongoing.
I
What?
love nothing on the social issue.
Any questions, anything else you want to see on that one?
Got dementia, so what's her story? I know you talked to family. Was that in the beginning? She had dementia in HPI?
I think it said something about
No.
discuss with husband and daughter outside the room.
Yeah.
All right, so a little more history is the home med list. A lot of home meds.
Yeah.
Not as many as some, but all those AccuChecks really clog up the
Yeah.
list. Any questions on that? Take a lot higher. Take a lot higher.
Why she's
We
on
have
tramadol?
twice a day.
on the old regimen.
Why she's on tramadol?
For chest, come in for chest pain, she has pain.
Yeah, I-
Yeah.
All right, review systems, physical exam, of course,
She's old.
for red, I don't, this is mine, so I don't do review systems because I
old.
graduated that attending level. but Residents still have to do a review system.
Yep.
It's like I forgot to take the no out when I edited that no regrets. And it says no mild moderate.
Oh, yeah, I didn't know that.
Any questions about any of that? Anything?
40 at a time.
Yeah, so aside from the part where it says the aberrant node is in the general. Typo, I think. Get into something we talked about a lot in orientation, making sure your physical exam captures. Especially if you think this is headed towards respiratory failure as a diagnosis. Making sure you capture a picture in that seems to fit respiratory failure and distress. So really focus on that respiratory section, describing the increased explicitly stating increased work or breathing, some tripoding at times. Anything else here? Assessment and plan.
As far as like trying to avoid those CDI queries, you usually try to put what you think the cause is, like for heart failure, acute on chronic or whatnot, suspect secondary to whatever. Or is that very important?
Causality for CHF is not something that should be queried,
Okay.
It's gonna be all about classification.
Okay.
It could have been a little more clear that the patient had no history of it here, but I mean, acute onset.
Finds it so.
He was in your,
I should have put type on it.
he was in your history, no CHL.
Is RPT?
Do we have previous echo?
Do what?
RPT, repeat?
Repeat.
Interesting.
It's all about
It's like.
efficiency. If you're typing it out.
RP.
And actually, that probably could have gone, I could have even done without that and just said IV Lasix 40 now, then, but I was just highlighting that it was an additional dose of IV 40 Lasix in addition to what the ED had already given.
They're gonna
It
start facing.
didn't start baseline insulin. not. I can put on our patient on home. We don't even know how much it's gonna be.
Well, you can do that's the calculation and then half it.
I mean, the assessment plan looks sufficient to the details, like enough to understand what's going on with the patient and billing thing as well. Like, you mentioned the CHF acute onset. We don't know if there is a previous echo we will add here or not.
What was our initial components?
We haven't labbed yet.
We get there.
Yeah, non-STEMI, the only thing is like troponin is not giving, but he put type 2 already. He put type 1. He put type 2 caused by CHF, which is
So I mean, that is the thing to start thinking about how you reduce your queries. In-STEMI is going to get a type. You just anticipate an in-STEMI, you need to put a type.
Where is it?
It's just at the bottom and I like it at the top as well.
I like it at the top.
That's just my personal preference. The
Yeah.
acute onset.
Typically, I do put it at the top, but it was more of a, after thought of I could put that in there.
If I'm on copy and paste.
But could also be.
Yeah.
So he's suspecting both.
No,
It's a
you
50-50
guys to be quick here.
It could be both, you don't know yet.
But yeah, you don't
So
know
for
which
the
way this is gonna
HFP,
go,
yeah.
because
Could be top 3, top 4.
cardiology does the cath and puts a stent in,
Yeah.
then we're gonna be calling this a type 1. Nobody does anything, we may be calling it a type 2.
Yeah.
So there are areas where you don't know at the outset, but one of the things I think is key, and we've been teaching a lot in orientation, is if you use your assessment plan to set up the things you have to figure out in the future, then it's always sitting there as a reminder of what you need to do. So even if you don't really know, going ahead and making some statement about it, then you have to look at it every day and then think, I need to update this. Well, yeah, didn't know, so I need to clarify. It's just something it's there as a reminder. I need to clean this up as this day goes along.
Did you talk about an EKG ever?
So that's all in its own section.
I know, I ain't got there yet.
I ain't got there yet. But, you know, things like, and other things that are good tips, if you go ahead and build them in your HMP to set up your progress notes from a billing standpoint, is already having things about monitoring hemoglobin daily, monitoring creatinine daily in the diagnoses where that's important, because when you carry that thing forward, now that's in your plan every day. So you're gonna get credit for that as to why you're doing it, because ultimately you can't just order labs and put lab results in your stuff and never link it to a diagnosis, or they're not gonna give you credit for why you did it. Another thing I like to do and have been trying to convince everyone to do is, I mean, every home med for the most part should be dealt with. I think the tramadol is probably the only thing on here that really wasn't dealt with, but I'm not sure that was that a legit home med or not, but everything, all the important like metformin, Januvia, every single medicine otherwise is dealt with, which I should have put all this on one slide, but started out with a different idea in mind. And so just rounding out this assessment plan, just even down to the donepezil, that way it's all accounted for, and then you're doing that med rec and it all just flows together. Because in the middle of the night, you're not even doing the med rec. So I think by going ahead and putting it in there, I've got a plan for this. Then if you need to do when you have to do your medicines, then you've got all that in your note, then you go through and continue all those and get them set up for the day team or whoever has to do that med rec, but particularly whoever has to do the discharge summary. All those medicines are accounted for. So you don't get 5 days down the road at discharge and go, well, we never started this medication. Particularly with like holding that. We didn't hold anything. Yeah, we held the metformin, Januvia, and glipizide. Like it's already accounted for as to why we held it. Sometimes you're holding other medications, particularly blood pressure meds, and their blood pressure was soft and you held something. It's just nice to call that out. So when you get to the discharge med list, you've already dealt with it. It's not something somebody else has to look at, because what happens, especially when we change services, the person admitting the patient is a lot of times not the person discharging the patient. And if you don't have that stuff accounted for already, now you gotta dig in 3, 4 days down the line and figure out why things weren't continued. And now you gotta make a decision on whether to discharge them on.
Do you put your PRN order in your assessment plan? Or did you order any PRN hypertensives because you did nitro paste to address high blood pressure? Did you order like beta law or hydroxyzine PRN?
May have, I doubt it, or I usually would put that in there. I think I was going with the nitro paste here just because of the pulmonary CHF, pulmonary edema, blood pressure. You can all accomplish with nitro paste. I don't think at this time I'd put that in there, but I typically would. Because that's from a medical decision making standpoint, that gets you credit. So it's just a good habit to put it in there. And you don't, sometimes I do the whole medicine, but sometimes abbreviating it to aspirin, beta blocker, statin, because the whole medication list is sitting right over there. So it's at least tying it into what you did, but you can do it much faster than, if you're dictating it out, I guess it's probably you're really not saving a lot of time, but if you're typing it, it's much faster to abbreviate. One thing I also think is key is putting your baselines for anemia and chronic kidney disease in there. You know, just because once you got that in there, it's always there. You're not ever having to look at it, think about it, particularly if you're on nights. You're handing it off to the day team. Like you've already had you should have already done that work when you admitted the patient. So gift that on whoever has to see them next by sticking it in the note in a nice spot where they can see that, and then they can move that every day, so they're not ever having to go back and go. And if you had to look back 6 months to find out what that was, why? If you set it up, you're saving somebody else the time to look it up later. So now here's getting into your diagnostics. Because there's actually separate sections in Cerner to put your interpretations and stuff.
You still get credit for it you put in your assessment plan?
No, yeah. You get credit for wherever you put it. Just don't like. I don't like putting it in my assessment plan because as I'm doing it, I can take that stuff and stick it in its own bucket over here. And then it's out of the way. And it's done. Because it's going to be really wordy. Time you put in a whole EKG interpretation, you stick that in your assessment plan. Now you've got a bunch of long sentences and words, and it messes up my very short. It really messes up the format to me.
Okay.
I agree.
I like the idea, like you compare the EKG with the previous one, and in a very simple, and change from whatever the previous one. So to give an idea of what's going on there.
See how important this little blurb is when you get into a coding standpoint. Because you have to phrase my interpretation on all of this in order to get credit for it. You can't just put the reports in there where you don't get as much credit. All right, so here's your labs.
Did we check iron stuff?
Sorry, hold on.
Not enough.
You said you don't too much while ago. Make your mind up.
Any questions about any of the diagnostics?
So you actually put the official read in your note too, and then your interpretation of it as well.
Yeah, because I tag when I pull that up to look at the report, I just highlight it and tag it, and it's just sitting there and pull it into your note.
And you want credit for interpreting it?
Yes.
Yeah, that's the key.
My interpretation of the impression is,
Like, hospital, I don't know. What do you mean by you get credit? You should ask.
So when you get into the data portion, we'll go through that in detail in a minute. As to how the different ways in which you get credit for the data.
Do we have a previous program to complete?
You never had.
She doesn't have a history, yeah.
no, but she got CKD stage 3, something. We'll never know.
GFR 44, so she's kind of A/B. Depends on the day.
Depends on his lazy.
All right, so when we get into how do we code this out? So we kind of talked about all just the documentation aspects of how you create good documentation that protects you from medical legal standpoint, how you set up future stuff, how you reduce queries, all that kind of thing, how you do it efficiently. Now getting into the actual billing and coding, nuts and bolts of how you get paid for all of that. So the 2021, which is the 2023, if you're talking about inpatient guidelines. So it goes in the, what we call the DDR format, diagnoses, data, and risk. And then each component gets assigned a level of, and then you take, but for the final EDM, you'll take the highest 2 out of the 3. So you have those 3 categories. And you can have a low level in one of them, but as long as the other 2 are higher, you can go with that for the final code. And so the quick example there, if diagnosis is 4, data is 4, and risk is only 3, then you could still bill that as a level 4. So moving into the diagnosis section, how would you classify the congestive heart failure?
Acute, yeah.
No, first, that was just a reminder of the diagnoses again. So really looking at, they all have categories for diagnoses, and how that relates to your MDM level. Typically, in the inpatient setting on an H&P, you're trying for a 5. You're trying to get the high level. As opposed to clinic where you're mostly trying to get a 4. So in order to get to a 5, you gotta have 1 or more chronic illnesses with severe exacerbation, progression, or side effects of treatment, or 1 acute chronic illness or injury poses a threat to life or bodily function.
So that's a 5. You're talking about respiratory distress with CHF.
No.
And
And then, so this gets in a little more in the weeds of what all the different definitions that are back on this slide. What exactly is a chronic illness with severe exacerbation? It's got a little more detail to it, but for the most part, self-explanatory. To me, it's when you get into the uncomplicated versus minor problem stuff. I think the higher acuity stuff is much easier to sort of. All right, so CHF.
And this is like fit to the criteria of like, it's going to be a moderate level 4 for the diagnosis.
Yeah, so how would you describe it?
It's like we got acute on CHF and histamine, which is also acute.
we don't know unless you got CHF in the past though. So this is an acute.
But it could be a chronic exacerbation here.
Yeah, so to me, because I didn't link it to like bodily harm, it's a little bit fuzzy to me. I would probably call it an acute illness with systemic symptoms, because it is it's an acute problem we didn't have a history of. This is all in the eyes, but coder.
But you're linking it.
You would link it to provide, what would you have said?
All I gotta do is make a statement that says
Basically that.
not new, like onset acute CHF, which is causing hypoxic respiratory failure.
You did though.
But you say how.
You said it's secondary to acute
But
CHF.
I did that in the hospital. That's what I'm saying. If you just this problem as itself, as it's documented.
Okay.
Yeah, the acute hypoxic respiratory failure to me is where you get the level. Because I think in STEMI, I think is a little bit more self-explanatory. Because it's
Yeah.
myocardial infarction, you got some stuff going on there, but not linked together to a life-threatening illness very well. A lot of people that have an instantly untreated and they're gonna survive.
I mean, I guess there's nobody that said, like, here's my question. You linking it to that, is that simply so the coder can pick up on it?
Yeah.
Because an intelligent coder is gonna know an instantly isn't. Life.
So it just depends on it. There's different thoughts of the way coders operate. They are not supposed to bring anything into the
But if you were
the
coding
determination.
yourself, you wouldn't code the survive.
Yes, but I'm inferring things that are not in the documentation. If you just pick on the CHF and the instant.
Yeah.
So I would think it would count, but it's one of those where it's documented on those two alone. It would be great. So whether you can get it by.
I don't even know how you document it instantly, like, if you want it, like,
I mean, you could always say patient admitted to hospital due to threat of arrhythmia from MI, which could be life threatening. I mean,
So if type 1, like what
if
you
you really
said,
wanted to link it, that's what you could say.
so if you said type 1, secondary to possible obstruction of coronary artery disease, I mean, would that link it or not?
You gotta link that. I mean,
Okay.
they wouldn't link to threat to life or bodily.
Opening like this and.
could have killed heart that could worsen number one.
I mean, I feel like this one's probably easier to just say it's all, you don't really have to explicitly get into it. But just for the sake of the point of it, sometimes you find yourself in a spot where probably a little blurb, and this will be a Dr. Martin teaching point when you get into that, is explicitly stating that always covers you because they cannot go against what you've stated. The physician documenting in the chart that this is a threat. They can't undo it. You would have to be totally out in left field, ridiculous for a coder to go against that. So for the insurance company.
So if you just
The
said,
insurance companies won't touch a lot of that if it's explicitly stated. I mean, especially with all the data here, and if they had a normal EKG and a normal troponin, well, then that's just all false anyway.
Right.
But in the setting of this, make an explicit statement always just as sort of clears the way for whatever it is you're doing. To me, it's the acute hypoxic respiratory failure, because acute hypoxic respiratory failure, you're already saying it is failure. And failure is automatically a threat to life or bodily function. So you don't have to explicitly state anything if you got failure in it. From a respiratory failure standpoint, that's where congestive heart failure, I don't know if they view that the same way. Because we have lots of people walk around with congestive heart failure. Now saying it's acute, I would think that would be a yes, but you don't know. And I think you could ask 10 coders and probably get several different answers. Now, of course, everything else is pretty chronic stable when you get into anemia, especially when it's all called out. Probably could have trumped up the type 2 diabetes because the patient did have hyperglycemia. And said with uncontrolled hyperglycemia.
Is number 7 chronic and stable if you think we're having anything?
Well, the way it's documented right there
Okay.
is coronary artery disease, but it's up in the top, it's type 1 versus type 2. So
That might change.
if it's type 2, then the coronary artery disease really is stable. It's just this new onset CHF, so. I mean, yes, it's there's a lot of gray when you start getting into these, but just making sure, it's not about making sure you got every single one exactly right. It's, do I have the ringer that gets me what I need, which is the acute hypoxic respiratory failure. So all those. And then of course, the hypomagnesemia is a new acute. Not stable, but sorry, that's a typo.
You get like 4 or 5 points here, so I'll give you straight 5 right now.
You only need one.
I mean, you need 1 already from the first one.
The acute hypoxic respiratory failure is
I'll give you
5.
5 right now.
Could be the only diagnosis in the whole H&P, and you got 5 from the diagnosis standpoint. But because you want to set up all those other things and get that, capture that, because you also have the hospital charge side of it, which is billing off up to 9, I think it's 9 different diagnoses that the hospital can put on their charges. That's why the queries come, because they want all that other stuff lined out to maximize and get paid for what we've actually done.
Team Health take 3 only, I think.
That's Team Health doesn't bill the hospital side. Team Health's only billing our professional fees.
Okay.
But if they
President.
were, if you work somewhere where you were billing against somebody, the more diagnosis you have, the more that don't overlap, and you can each individually bill for, right?
Right, so once you consult cardiology, you're gonna lose the CHF and the NSTEMI likely.
Not if you get your note in first.
I know that. But this H&P is definitely been dropped first, so you don't ever have to worry fighting on that too much with an H&P. Unless you consult them same day.
So is she on oxygen at this point?
That's what I was gonna ask.
Because we said she wasn't tolerating
Which one?
bypass,
BiPAP.
but she took it off.
Wasn't it?
He's tripod.
Physically saying.
I don't remember, that's why I was asking.
It was not in the physical exam, but I know.
We don't have an
Because
ABG.
what do we know? Yeah,
She's
we're at the
on 40%.
hypoxia.
She's on a 40% anyway.
But no, the vitals say bypass, but we said in our note that she didn't tolerate, so she took it off.
Yeah, I think she's just on oxygen.
Okay. And just being on oxygen,
It's.
we can call it
I didn't
hypoxia.
call out exactly what she's on, but she's on supplemental oxygen to keep that.
You don't need an ABG to do that. She's on oxygen. Good to go.
I mean, if you have that SPO already down below 90, that's, 88, then you're good to go.
There was an ABG somewhere I still. Ran out of space on that.
That's what I figured. I was like, surely there was.
There's wasn't room in that diagnostic section. All right, so now moving into the data. We're trying to get to that level 5 again. So the understanding the difference between level 4 and level 5 is important. It's the same categories. It's just different requirements. So if you can remember one, you can remember them both fairly easily. So level 4 is you only have to meet one of the 3 categories. And category 1 being 3 of those external notes, results, order a test, or talk to an independent historian. Category 2 is independent interpretation of tests. Category 3 is discussion of management test interpretation with an external provider, which external provider means anybody that is not your same specialty in your same practice. Level 5, the only difference between a 4 and a 5 is that in a 5, you have to have 2 of the 3 categories instead of 1, which is where the independent interpretation of tests becomes very important when you're trying to get level 5.
And you already get 5 here from category 1 and 2, already from the category 2 by itself.
You have to have 2 of them.
Yeah, to get a
You got
5,
one.
though, you gotta have category 1, either 1 and 2, 1 and 3, or 2 and 3.
And an ER provider doesn't count for the category 3.
Those.
It does. So if you long as you talk to the ER provider,
But he did talk to
You
you.
discuss with the ER doctor.
Did you?
What?
You didn't document that, did you?
He did.
I did.
No, he didn't.
And that's all you gotta say. I mean, there's not. It does not have to be any,
Where'd you put that?
what?
Where'd you put that?
That's from the
You put it in the
HPI.
SPI.
Oh,
This is when I said the ABG didn't go on here.
Okay, I was like, where is that in the chart that you can put
Yeah.
that?
It was in the SPI.
It's at the bottom of the HPI. I don't like. I put it in the HPI and then it's
Yeah.
out of the way because I don't like it in my assessment plan because then it's.
That's where I usually put it
it's
too.
more
I, it
wordy.
looked like it was like over on like
And
the
you're not,
right
and
side.
you're not gonna carry it forward.
Right.
All right, so from a data standpoint, how much category 1 data do we have? So out of that category, it's every single unique test.
You get the ED, and you get all the tests.
you didn't. You didn't order none of these tests, the ER did.
but you get for reviewing.
Okay.
Yeah, so whether you order it or review it, you can't get credit for both, but you can get credit for either or.
Okay.
So as long as the ED orders it and you review it, you're getting credit for the review.
Now, the test that you order for the next day daily, you get credit for that too.
Yes.
The reviewed
I
some.
didn't figure
And the
that- I
echo.
didn't even figure that into this, so.
You need to
monitoring
mention
daily.
Do you need to mention you reviewed those labs or just reviewed all the labs, whatever?
I mean, by addressing them in your assessment and plan, you're creating the story that you actually did something with them. So, and then
Makes sense.
you put them in your note. So you're getting credit for having reviewed them just by putting, but you actually have to have the actual number in your note. You can't just say CBC review.
Okay.
Maybe you could, but depending on, I mean, it gets into, you'd have to have a pretty liberal coder to let you get away without at least having the exact data in there. I counted through this, I think it was about 10 different tests just in this, because the CBC, there's a PT, a PTT, a CMP, a lipase, MAG, CK, troponin, BNP, TSH. So 10 unique tests in there. Because you don't get credit for all the different components of the test, just the main test itself. And then, of course, the CTA is another one, and then there's 12 because of CTA and CTA,
ABG.
and then the ABG would have been another one. Yeah, so there's a ton.
There's
Most admissions, category 1 is so easy that you're not even out of work.
UA.
You don't even count the unit. What do you mean?
Can you count the CPs, even if the radiologist?
But he interpreted them, so they count.
So, well, you can count it here. It always counts as category 1, just the report, because you reviewed the results. Now, so category 2 is independent interpretation of test. Which I don't have my piece on here, but I clearly documented, I reviewed the CTA. And then my little short, and it doesn't have to be much. I mean, it just has to be a couple of things you really looked at and focused on. You're not responsible for being a radiologist.
Right.
You're just responsible for looking at the scan and making some interpretation on the clinical correlation piece of it really is what you're responsible for.
Ready to get a chest X-ray at all? With respect to the CTA?
That's with the chest pain, the back pain.
Yeah, yeah.
I mean, is that uncommon from our ED? No.
I mean, the only thing he didn't address here is the leukocytosis. You never mention anywhere.
Yeah, I mean, yes, you're right. I mean, I should have put leukocytosis in there and said it was due to NSTEMI and stress with CHF and moved on.
Everybody will listen. Where is the UA? Where is the UA? Let's see.
All right, so there's at least, so in this, there was actually 2 different category interpretation studies. So that, to me, there was 2 different elements of satisfy category 2. There's not on here with their interpretation. So in category 3, we talked about category 3 is discussion with another external provider. So discuss with ED provider, checks the box for that. So then this is a level 5. Yeah, so this is solidly a high level 5. All right, didn't edit that one. So now getting into risk. So risk in the inpatient setting is, there's just some real like tricks to what gets you risk. One of the keys is any decision regarding hospitalization or escalation of care is an automatic 5. So it's a pretty, on H&P, you should, like, you've got a 5 here every time.
Okay. Do you have to state specifically why they're requiring hospitalization to get the 5, or just H&P?
So I just put in my number 1, like the CHF, admit inpatient to CTU. So it's just a clean statement of we're admitting the inpatient, not, you're making it clear that we're inpatient, not OBS, and they're being admitted and where they're going to. To me, that's just a nice, clean way to do that. Get all your credit. it's tagged a diagnosis when it's in your assessment plan, so I don't feel like you need to go through the trouble of spelling that out when you've already put it for the assessment plan for a problem.
Is the observation that doesn't give you a 5, straight 5?
Yeah, I mean, it still does.
Alright.
Yeah, that inpatient versus obs is just if you get into the Dr. Martin world where the insurance may deny you obs versus inpatient, it's nice to have a statement where you said explicitly this patient requires it. You've made a statement about whether they need inpatient or ob. It's just easier to defend on the back end. So it's just a good habit. I'm sure he would tell you to write a lot more than that, but until they start clawing at me, I'm gonna keep it short and simple.
The decision to DNR, is that on admission if they're already DNR?
Anytime you change decision to make them DNR, de-escalate, go to comfort measures.
But if you change, so if they come in DNR already, like on admission, they say,
It didn't help you any because you've already your admission already got you the 5.
gotcha.
It's if you have to de-escalate, if you admit them as full code, they're getting worse. And then 2 days later, you have that discussion and change them to DNR or comfort measures.
But you don't really need it because you already admitted them inpatient. You already got the 5 anyways.
Well, but you got your 5, but that game is every day.
Oh, every day.
Yeah, so your progress note's gonna get judged.
There's no rest for the weary, sir.
Yeah, I mean, every note you're doing is getting judged the same way.
Oh, okay.
So, yeah, capturing that DNR change helps you will get you a 5 that day in risk standpoint.
So if you say this patient, you got them on Lasix, whatnot, you're monitoring creatinine, potassium, would that count as intensive?
It's a minor, see, it's one of those gray areas that I'm really not sure what the answer is. I would say yes, because it's explicitly stated that you have to do it because of this. And that's why I put that, like, you put that in there, you're linking why you're intensively monitoring them to a treatment. So the medical decision-making that you do every day to do that, you don't get credit for it, some of it, unless you put it in there. We have to do this because of this. It's also helping justify why they're in the hospital. Of course, to me, the heparin drip gets you drug therapy requiring intensive monitoring. Sure. I don't explicitly state that, but that's one of those where I think most coders would probably give you credit, but I don't know. Like I said, I like the potassium creatinine because now that sets up your tomorrow's decision making. Because now you can argue that it's a 5 on tomorrow when you don't have your decision to admit. Well, that decision was already made yesterday, so you don't get to make it again today. So now looking at our MDM risk, and then so what PO, continuing like home PO meds, what level would that be?
You already did like the highest is 4, I think.
It's a 4, 'cause it's just prescription drug management, so that's all you get for anything non-intensive monitoring. So the IV meds, we kind of already had that discussion. You could argue 4 versus 5. Heparin drip, already talked about that. That
Straight
is a 5 to me, because that is definitely intense monitoring. Decision to admit is always a 5. Sorry, MDM risk level is a level 5. So we're kind of wrapping up with the coding summary, the diagnosis, we had a 5, the data, we had a 5, the risk, we had a 5. Or finally, an M code assignment,
5 right away.
it's gonna be a 5, except it's not a 5 in the inpatient.
What the heck?
Yeah, but you go high, yeah, there is no 5.
There's no 5 in the inpatient.
You go with the
221,
highest.
222, and 223.
Huh.
And 221, 222, 223.
Or H&P?
They make it
H&P is 223, it's 221, 222, 223. Progress notes is 231, 232, 233. Inpatient actually is where you have the 5 codes and where the level 5s come into play.
Can you only bill for one 24-hour period? So if you admitted somebody at 5 o'clock in the morning, they go home at 5 o'clock that afternoon. Do you get to bill twice?
No,
Hospital, you only gets one bill.
that's a really tricky thing now that I would have to look at.
I didn't know.
There's all kinds of rules with that. If it's the same person who did it both times, you can bill and admit discharge same day code. Like there's extra codes for those situations. So like anytime you have a
A
weird,
short stay.
yeah, anytime you have a weird situation, there's special codes for that on the inpatient side because the admit discharge could be in the same 24 hours, it's in the same calendar day. It's not about 24 hours, that's all about midnight.
Okay.
It's all about same calendar day. Then you get into some weird rules of if they're there for 8 hours or less, I think it's an 8 hour cutoff.
Mm.
And it's somebody else, you can bill extra. But like if I do the admission and you discharge them 6 hours later, I don't think you get the bill for a discharge. Don't hold me to that. But there's some weird rules around. If you got them for longer, if you got them for 10 hours, then you actually get the bill some sort of discharge code. You know, on top of my H&P. So it's really, that's some of the newer changes that are complicated and doesn't happen very often that you're discharging somebody less than 8 hours.
Right.
But from a thing, any after midnight admissions can't be billed by the day team if they stay.
Right, so they don't even do it.
If you admitted this patient at 2 a.m.,
Yeah, they don't even do a real progress note the next
the
day.
day shift is just doing a progress note to set, to me. See, I do a full one because if I'm gonna turn around and see them the next day, I might as well go ahead and have that thing set up.
Yeah.
Now I'm going to be billing the next 2 to 3 days.
Right.
Cause if you're gonna have to do the work at some point.
Yeah.
Why not do it on day one when you're learning about the patient, set it all up? Because it does, if you have a good H&P that's kind of leading you down the road of echo sets on there, well, I know I gotta have an echo result put in this chart. So I know to follow up that echo every day because it's sitting right there, telling me it's ordered. If you set an H&P up, it flows to the next person that picks up the patient. Here's all the things you need to follow up on. You know, just a simple cards consult on there. I'm gonna put a colon on that one, and then every day I'm gonna put what I talked to them about. A lot of times I'll just say discuss with cardiology, comma, whatever the plan is. Because you're gonna talk to cardiology every day on these patients. So you just keep carrying that discussed with on through and it sets up all the billing. References. Any questions?
What you have? Is it a bad echo? Come on.
Night shift.
I wanna know the rest of the story.
Listen, night shift, the rest of the story is I survived till 7 a.m.
Turns out it was COPD the whole time.
Maybe it was.
Yeah, that we never addressed.
I'm waiting for a
White blood
feedback
cell
form.
count was
I
up.
never got a feedback form, so I guess.
White blood cell count was up.
Look at
COPD.
No feedback form.
Shame.
Lucky you.